Hey, welcome back to Injury Territory. I'm Will Carroll, part of the Foul Territory Network. You can get you one of those hats at our store. But I'm excited about being back this week. I was just at Sabre Analytics down in Phoenix. Tons of stuff going on. I'm not going to talk a ton about what I saw in terms of research. There was a ton of it. Or the stuff about ABS, which the automatic ball and strike challenge system, which we've seen in games, but learned a lot about it. The biggest thing I learned, the strike zone's completely different. Everything we learned growing up about the strike zone, where it is, what it was, I'd always thought of it as a cube, you could hit any part of it, just tap it. Uh, Really, the entire idea behind backdoor sliders. But nope, those don't exist anymore. Now the strike zone is a window. It goes straight up from the sides up to a measured height, which they're doing with motion capture, if you can imagine that, for each and every player. It is not dynamic, it's static, and it is a window. That ball has to touch that window and kind of break the glass somewhere on there. So we'll go over a lot more on this once we start seeing the results. They've been all over the place. Some catchers are really good at it. Some hitters are really good at it. I wrote at undertheknife.substack.com on Monday about how this is going to tell us who really does have a good eye. It's always been one of those cheers that I'm like, good eye. What does that mean? Now we're going to actually be able to see exactly where that is. But let's jump into the injuries. And the big one this week is Giancarlo Stanton. Now he's out there, he's playing, but how well is he playing? We know he had that the elbow issue last year. It was kind of tennis elbow. It's kind of things you see for golfers, for rec league tennis. It is a thing, epicondylitis, but he rested and he came back and he hit enough. But now this spring, first he was saying everything's great, it's going to be manageable, we're going to have to deal with this the rest of my career. I get it. But then he's telling people he can't open a bag of chips. And even this, I can't figure out because, sometimes bags of chips can fight back. I get it. You grab them, you're fighting with them, but that's not really the motion that should do it. So is he having muscular pain? Is just that tension causing problems for his tendon? That would suggest a lot more than just the epicondylitis, the tennis elbow. That would suggest tendinosis, that he's actually having cellular changes inside that elbow, that things are not going well on a cellular basis and is causing him pain. If it's degenerating that significantly, yes, they can continue to manage it, but for how long? I think that's going to be the biggest question. How are they going to maximize him when he's healthy? If they find something that works, if just the planets line up for Giancarlo, then you get him out there and you hope he goes on one of those hot streaks like he did a couple Octobers ago. But this one, you're talking about collagen fibers and tendon remodeling, and with someone who's generating such enormous force through his forearms, he can't stabilize the barrel. He can't control the motion. I'm very curious if pitchers will challenge him with a lot of motion, movement, that is, try to get him chasing sliders and extending out. Uh, at some point, he's not going to be able to control his brain because the brain is going to protect the tissue by reducing the force output. And that means the bat speed dips, the exit velocity follows when he hits it. A hitter can't compensate for force production the way he can adjust for timing. We've seen these before. Ken Griffey had it at the end of his career, along with everything else. Prince Fielder had a lot of forearm issues. The torque in his swing was somewhat diminished. And probably the best example here was Nelson Cruz, because he had similar, never seemingly quite this bad, but aggressive maintenance where he was carefully structured workload. He didn't take a lot of batting practice. So we're going to have to see exactly where this goes. David Ortiz is another one. Uh, I think Stanton, obviously in great shape. I mean, he looks like a Greek god, a statue, but there's a crack in the elbows. Those tendons not holding up. This is a leading indicator, and I'm very worried. If you're getting set for fantasy boards, I'm taking him down. I'm wondering how they're going to fill in behind him. Does this mean Aaron Judge is going to play more DH? Could that help him? Lots of things, but we're going to have to see how the Yankees deal with that. The other one I want to talk about just real quickly, Zack Wheeler. He's coming back from thoracic outlet syndrome. He's been doing bullpens. He's at about that 6 to 8 month mark where you normally see guys return. He's throwing well. He says he's feeling good. What I want to see is he comfortable? One of the things I saw is that he looks a little tilted. And you'll see guys like this. Now, remember, he had a rib removed. So I'm sure he's not entirely comfortable with it. But every time I see him talking, he's just a little tilted, as if he's guarding, as if he's not comfortable with that decompression. We'll see exactly where that one's going to go. I want to see how does he just move? Can he get into a rhythm pretty quick? I'm excited with the idea of having Zack Wheeler back, but I don't know if we're going to see those ace level kind of things early on. The other thing that's coming up really quick, World Baseball Classic. Everybody's getting ready for it. So let's talk about how you're going to watch it. Of course, all our Fox coverage is brought to you by our friends at Fox One, which is live. Stream all your Fox favorites together in one place, including all WBC games over the next few weeks. And after that, the best MLB action all season long. From the WBC through the World Series, World Cup, NASCAR, and IndyCar with Fox One, you get it all live. Start your 7-day trial today. Offers subject to change. Download Fox One today and stream the World Baseball Classic live March 6th through the 14th. Go to fox1.com for complete terms and condition. Fox One, streaming now. So let's talk about the WBC. There's a number of things going on right now. We've already lost Joe Ryan from the U.S. rotation, that back injury. He's getting back on the mound, not too worried about it from the Twins' perspective, but they've had to replace him. Now we're hearing Nolan McLean is having some vertigo symptoms. That's not good for pitching. I'm very curious to see how they're going to deal with this because there's already a fairly tight window. There's already restrictions on how guys like Tarek Skubal and Paul Skeens are going to be used. There's a number of things. You have to realize this first round shouldn't be a problem. They're facing teams like Brazil and Great Britain. Skubal against Brazil sounds like a mismatch to me. No offense, Brazil. I've got some friends that are working with that team. So to me, I'm just curious to see how this is going to go through. There's been knocks on how they're setting up, how they're being restricted, that Skubal's only making one start. I'm still unclear on how this is actually going to play out because there's so few games, and the ones that matter are at the end. Those are the ones you can't really plan for, and that they haven't. Mark DeRosa hasn't made it clear exactly where they're going to put that. There's going to be a lot of relievers. There's going to be a lot of short usage. There's going to be, again, the restrictions are going to come into play. We're not going to see guys come back on short rest. However, could we get to that finals game? Could we see US, Japan, and all of a sudden now we've got everybody available? Absolutely. It's going to be a Johnny Holstaff game. It's going to be, if not 1 by 9, it's going to be really, really close. They're going to save some bullets in the back. Maybe we see Shohei Ohtani. He's already joked about it, but I'm not terribly worried about the injuries. Again, Ryan out, McLean a worry. How do they replace those innings? We'll see, but there's a lot of arms, a lot of ways to use them. I'll be very curious to see how Mark DeRosa does that. Excited for that WBC coverage. Again, thanks to Fox One for sponsoring all of our WBC coverage. Now, let's get to the interview with Dr. Chad Lavender. He's out of Marshall. He's created a absolutely new surgery called Lavender Fertilized ACL. If you haven't read my writing on that, go back to Under the Knife. .substack.com and check out what he's done. There's some amazing results. A girl named Audrey Biggs, you'll hear me mention her in the interview. She was a basketball player in high school, came back in 6 months, 6 months almost to the day from her ACL surgery, played, and now she's at Pittsburgh on full scholarship. Once they saw her playing, they realized, oh, yeah, she is coming back that fast. Now, it has been used a lot at the highest levels, but he's gotten some great results. We're going to talk to him about the state of the art and where the state of the art is going. This is Chad Lavender.
Hey, I'm so excited to be joined by one of my favorite doctors around, and there's a bunch of them, but one of the first calls I make anytime there's a knee injury is going to be to Dr. Chad Lavender. He's an assistant professor with Marshall Orthopedics and the founder of what is called a fertilized ACL reconstruction. And we'll talk about that in just a little bit. But Dr. Lavender, let's talk about not just knees and shoulders. I know you work on everything, but when it comes to the kind of restorative medicine and scientific based medicine that we've seen over the last, let's say, decade, probably 20 years going back, how big of a change is it? Would you say this is one of the biggest changes we've seen in the last 50 years, that we're getting people not only back, but back faster, back even better?
Yeah, I think it's interesting because when you talk to physicians across the world and you get a group together, the timelines really range, right? So from as early on as 6 months to up to a year or more. And a lot of what we know is that it's patient specific, technique specific. Also, I think there's some cultural things that have to do with that, but it's really all over the place. But I think what we've seen the biggest change in the last 5 to 10 years is the ability to use biologics, and then also not just biologics but reinforcement technologies, like the internal
Yeah.
brace, for example, or suture tape augmentation. I think, you mentioned the fertilized ACL, and honestly, in my opinion, 7 years ago when we did that, what we did is we started a thought process of augmenting ACL reconstructions and repair techniques across orthopedics. And I think you've seen that just blossom with all the techniques and research that you see now. Really, everything's focused on how to improve ACL reconstructions in addition to other in addition to other surgeries, right? So you see a lot more of that than what we saw 10 years ago, right?
Right, exactly. Now, let's explain to some of the people who might not understand some of the things, two of those things that you talked about there. First was augmentation, and the second was biologic. Let's start with augmentation. That can be, we all hear the term internal brace now. There's multiple techniques
Mhm.
like that. I think that's kind of become the generic, almost like Tommy John surgery. But tell us what that augmentation is and why it makes such a difference.
So there's different types of augmentation. What we know is that when we started down this road, I would say 7 years ago, re-injury rates were anywhere from 6, 7 to 15%, in some cases higher than that in certain athletes. Our team said that's just unacceptable. And so we started augmenting with biologics, in the form of bone grafting into the femur and to the tibia, with using the patient's, mainly using most of the patient's own cells, and mesenchymal cells that we use from the shin bone. Okay, just a bone marrow aspiration. And so we created a mixture to do the bone grafting. And that's what I mean when I say biologic augmentation. Suture tape augmentation is a reinforcement that is a suture that stays in the knee or across the elbow, whatever you have, and would stay there and reinforce, especially in the early period of the recovery when the patient's trying to get back to sport and the repair or reconstruction not fully healed yet.
Right.
Then you have, so that's the fertilized ACL, right? Biologics and structural. Um, I always used to say 7, 8 years ago, and you've heard me say this at many talks. I'm not sure that our composite mixture is what's going to be used in 10, 15 years, but I can tell you that the need for augmenting repairs and reconstructions will even grow, and it has, right? So you've seen that in the world, right, with Tommy Johns and all kinds of different surgeries. Specific to the ACL, what we're seeing more of is the LET or extra-articular tenodesis, being added, and that's a second or a secondary type of augmentation procedure that can improve your results after ACL reconstruction, namely decrease the re-injury rate. We're getting ready to present or to publish that's been accepted our 3 to 6 year follow-up of 100 patients, and the re-injury rate was only 3%. The contralateral tear rate was 10. So, meaning the non-injured knee, right?
Right.
It tore in 10% of the patients. We're starting to see longer term evidence mount up for these augmentation type procedures.
Now, with your aspiration, let's talk a little bit more about that, because most people, when they think biologics, we're getting either something like a PRP or other injections, whether that's their own or whether that's something external. We hear so much about peptides these days, whether that's in terms of weight loss or weight gain on the bodybuilder side. But so many people willing to experiment on themselves. But you drill in there, pull out those mesenchymal cells. Um, why aren't more people doing this across other body parts? I know you're leading the way with the knee, but we do see augmentation. In baseball, we've seen thumbs for years. It used to be a 3 month injury. Now it's a month because of the augmentation. Same thing with the ankle in soccer. It was 6 months for a major rupture. Now it's 3 months. When you're talking about biologic agents, why do you think we're not seeing that as much as we are with the augmentation? Suture tape and similar has been adopted across virtually everything. Fertilization or other biologics, less so.
So a lot of questions you asked there. I'm gonna try to piece that back together. So first of all, I like to say what we do with our biologic augmentation is called directed cellular therapy. We're taking cells, bone graft, and we're placing those into the femur, into the shin bone, where we know the reconstruction's happening and they're going to have a positive effect at increasing the tunnel healing of the ACL graft, right? And not dilating the tunnels. So we call it directed cellular therapy. For years, the PRPs and all of those other types of injectables, kind of what you hit on, people were just injecting into the joint or after a rotator cuff, injecting up above it and just hoping that the biologics made a difference, right? And what we found is it really didn't make a dramatic difference. But now, by being able to incorporate those biologics into the actual reconstruction makes a big difference in the outcomes. Okay, so that's first of all. Now, why are they not used more widely? Well, I've learned a lot in the last 6-7 years. It takes a long time to prove in randomized trials and prospective and retrospective trials with imaging, with hop test results, with all these different ways to actually find differences and then prove your differences. And I think so that's one reason is it takes time and even on the internal brace suture tape augmentation side, there's still surgeons out there that don't use that and feel strongly in their results. And I think that it takes time for surgeons and for methods to change methodology and techniques. But the biggest issue is cost. And so there is an added cost to the procedure. We've done initial cost analysis on the procedure that very favorably point towards using the biologics. However, we're going to do that's on my to-do list for 2026. Now that we have 6 years of evidence, we're finishing up a 125 patient new prospective study. We're almost fully enrolled in that one. So the next step is going to be looking at the cost and, is this something that is worth going and trying to get a code for to make it more reasonably and cost effective from that standpoint?
I think when you're looking at a general population, that's definitely going to be the case. But for the athletic population, the fact that you can get them back quicker has a real value. if we could get a pitcher back in 12 months versus 18 months, if you could get an ACL, a football player back in 6 months versus 12 months, or 9 months now, we see is pretty much the regular for the NFL. That's a huge value. I mean, 6 months isn't going to get them back in season, but it's going to give them
Yeah.
that much more time to continue to rehab and strengthen and everything. Um, and you've seen some rehab times that are even less than that. Talk a little bit about how quickly you've seen athletes come back from that. I know, actually, it's crazy how many times I check the Pittsburgh women's basketball scores to see how Audrey Biggs is doing.
Yeah, she's one. I think she came, back at around 5 or 5.5 months. And her story's out on the internet, so um but I think here's my thought process on return to play, and even everything that we know about return to play, and there's so many different factors, and we could do a whole show sometime on just returning to play after ACL injury and all the different things that make a difference. But I'll give you my thought process on it is, um, we've really strayed away from, there was this stigma or negative, um, uh, this perception, if you will, that was out there that we were letting patients get back at such an early time frame. That really never was true, as you know. Like, I mean, we stuck to a 6 month time frame for the most part, with the exception of extraneous circumstances, 6 months for return to play, which is much earlier than the 9 to 12 month traditional recovery. And we've published really good results with that. And I think that, and I've also heard other surgeons say this: if you want to improve earlier, you have to start early in your recovery process, and that's where that internal brace comes in, and really getting your function back earlier, I think, matters. So, 6 months is reasonable. I've really focused my attention more so, though, Will, on long-term results, and how are they functioning when they go back, right? So now we're doing a lot with Dr. Hewitt, as you know.
Mm-hmm.
We're doing a barrage of testing on patients at the 3 month, 4.5 month, and 6 month time frame, and then we'll go back and look at those results and see if there's any correlation to their overall results in 3 to 6 years. And I think that's when we'll really start having a great idea here of our return to play, and were the patients that were ready to go back at 6 months that scored well, how did they do long term, right? So that's what we need to see. And kind of the next phase, with the fertilized ACL is, okay, we release them at 6 months. How does that correlate 3, 6, 10 years down the road? I think will be really important.
Yeah, there's so many times where return to play or really return to competition is determined by the calendar rather than by when they're actually ready. It's so difficult to determine that. But one of the key things I think I've seen with your work and what you've shared with me, which has always been, let's be clear by the patient, that he's not secretly sharing stuff with me. But I remember you had one patient who was walking just days after a major ACL reconstruction, and I forget his name, the motorcyclist.
Oh,
Or
yeah,
he was running,
yeah,
if I remember correctly, just weeks after.
right. And some of those things got twisted, as they do, as well as I do in the media. But I think now, regularly I'll have them jog lightly in the office at their 6 week follow up. And if they're not jogging, I tell them before surgery, I say, I want you to be able to at least show me that you can form lightly jog at 6 to 7 weeks out. Because that shows me that their quad function's improving and they're psychologically feeling better about their knee and all of those things, right? So we definitely don't want patients out there decelerating, hopping, or pivoting, but a gentle move forward, and strengthening is acceptable at 6 weeks, even. And so again, I think those activities, and you mentioned walking. I'll tell you a story. So this is interesting how research I was up on the podium a couple weeks ago and I said, listen, the one thing I know about research is for every question you answer, you have about 10 more questions that you need to research, right? So our first study we did, there was, I'd say it was 10 or 11% return to the OR for some stiffness. And we just didn't see that in our general population, especially our out of town patients, right? So the patients would fly in, I'd tell them you've got 2 weeks here, and then they would go back home at 2 weeks and they'd have all their motion. And so I came to two obvious answers to that. I said it's either because those out of state patients, they come here, they're more motivated, they do therapy each day and sometimes twice a day in some of the cases you mentioned, or they just really want to get out of West Virginia and they know I won't let them leave until they get their motion. But what we found is, I went way back, okay, and I started using an old thing called the CPM, which is a machine that moves your knee. And we give that to everybody, and it decreased that rate from 10% to 1%. But it's vital for what you mentioned, getting back early to sport. You have to get that motion really by the 2 to 4 week time point. It has to be there so that you can move to the next phase. And so the CPM, we've got a study a manuscript that we're putting together on the CPM use and how it changed our recovery times.
When you're looking forward, I know you're working on a ton of things. Some of them you can't mention here, but
Maybe I
is
can, you know?
is there still things that you're looking at that can take that rehab time down, that can make the surgery, less invasive, or less damaging from the inside? I know that sounds a little crazy when you're repairing something, but if you're cutting somebody open and taking things out, I recently saw a thoracic outlet surgery, and it was crazy. I mean, it was masterful. It solved the problem,
Mm-hmm.
but watching them chisel out the first rib looks more akin to carpentry than anything else. Where do you see the next 10 years going?
So, specific to ACLs or
Just
across
in
the
general,
board?
just in
Yeah.
sports medicine.
In sports medicine, I see it going. I mean, it's probably a good lead into talking about nano. The nano needle, and I mean, I don't know if I have any of my old books, but I wrote a book on the nano and biologic techniques about 6 years ago. You remember, and
Mm-hmm.
um, at the end of that book, the last chapter, I said, here's the thing, Will. When you and I go watch games on Sunday, and you sit there and you're watching 10 TV screens, right? And some of them are 120 inches. I always said to myself, it doesn't make sense that we're doing surgery on patients with one view and one 40-inch, 35-inch TV screen, or maybe two, right? I mean, we've got
So
all
you're
this
saying we
set
need an
up.
OR that looks like a sports bar?
Yes, that's what I put that in the last chapter. I said we need to advance to surgery to where we have multiple views at the same time, larger, more immersive experiences in the operating room. And here we are later, now, and really we're getting there. With we are showing with the nano needle. First of all, the nano needle HD is out. So the
Right.
nano needle, for those of you that don't know, it's the size of an 18 gauge needle, which is a very small needle, but gives you a view of the joint, right? And we've
Yeah.
shown in multiple studies that it actually improves patient outcomes and decreases their need for narcotics after a standard knee arthroscopy or sports case.
Which I think is one of the key ones. Let's go back just a little bit, because
Yeah.
I wasn't going to bring up the nanoscope, but let's talk about it a little bit. Everybody kind of knows what an arthroscope is. A nanoscope, or nanoneedle as you're referring to it, is much smaller and on the order of what you'd get a shot with, correct? With the 18
Right.
gauge.
Correct. Yeah.
And so you're able to go in there with this much smaller needle, not just look around, but actually do procedures. Which procedures can you do with the nano currently?
I mean, you can do any procedure with a nano,
Well, I can't do any of them. You could.
and yeah. So in a mixture, in some cases, like when you're doing a PCL reconstruction, you use it for safety to put it in the back of the knee. Other cases, like a rotator cuff, it can help your visualization. And then the most common use is obviously for a standard knee scope. And what it does is, it, like I said, you're pumping less fluid into the knee joint. Like you said, about it being a brutal, or not brutal, but carpentry type surgeries. We can take those and make them much more minimally invasive on the patient. You're talking about really not making incisions at that point, but still having devices to be able to do the procedure and to be able to see. And the thing that's changed, and this gets back to your original point as well, how have things changed and how will they continue to change? It's moving at such a rapid pace, it becomes hard to predict. But today, now we have an HD nano needle, which, is way better than the resolution we had before. And I think there's really going to be some exciting things in the next 6 months to come out, nano related. But right now we have a nano that's an HD visualization tool, and we can pretty much do, you could do any procedure. It just depends on when it makes sense. If you're already making a large incisions, like with an ACL, for example, probably wouldn't make the most sense to use a nano. But if you're doing a repair of an ACL, nano would make sense, right? So you're not making incisions, you can do a nano assisted. And I think having it as a second option for viewing purposes that we've shown in multiple techniques really just changes the whole way that you can do a procedure, and the safety and the effectiveness, I think, bears out.
One last question for you, Chad. We're coming up on the NFL Combine. It's here basically in my backyard in Indianapolis. There's going to be a lot of athletes coming through that have had ACL injuries previously. They've had them repaired. They've played with them. How much do you take that into account? A past ACL injury when you're evaluating a player?
So that's a great question, Will. And I think, the best way to answer it would be, first of all, the number one, when we take away everything as far as risk factors for recurrent tears, or like you're saying, could they return to play? The number one risk factor you generally will always boil down to, just like any other disease process, which is the amount of risk that patient takes. Okay, so let me give you an example. Someone that's going out for the NFL is going to have a much higher risk than if I had my ACL done, the same surgery, same technique, whatever,
Yeah.
and I'm just trying to ski a couple times a year. You see, so those are entirely different risk profiles. So just from the inherent risk of trying to play in the NFL after an ACL,
Mm-hmm.
they're at risk. Okay. What we do know is they're at higher risk, generally 2 to 3 fold higher risk for tearing the normal native knee than the operated knee. And there's a lot of theories out there really past this discussion on why that happens, but that's the truth. I think um, we've reached a time point, though, with ACL surgery, that the stigma that you've had an ACL, in my opinion, in many people's opinions and surgeons, that stigma has lessened to a major degree, if not completely vanished. Okay. I'll give you an example. If you go in a locker room, and you've done this, right? You go into major league locker rooms all the time. If you were to have a stigma around who's had Tommy John surgery here, you probably wouldn't have many players left, right? I mean,
Take out a third.
yeah,
It's
a
a third
third.
of pitchers
So
in MLB.
and that's what we know about ACLs. I mean, especially in certain high risk populations like women's soccer and some of those different sports. You mentioned motocross, for example. If you were to negatively place a stigma because they've had an ACL reconstruction, I think that's not a good evaluation with how good our techniques are becoming. Like I said, 3% re-rupture rate at 6 years is very good. The ones that are getting LETs now are around that 3 to 5, I guess, range as well. So it's also down. And I think that we're finding better ways to do the fixation methods are better. You've got more graft options now. You add in the biologic treatments and the internal brace or suture tape augmentations that are out there, extra articular procedures. I think that we're making a lot of progress to where if an athlete comes into any combine, or maybe they're in the transfer portal, that you wouldn't negatively assess that because of the ACL.
That's Dr. Chad Lavender. He's out of Marshall University, where he's an assistant professor, one of the top knee surgeons in the world, one of my first calls. And thanks for taking the time to come into injury territory.
Anytime, Will. I really appreciate it. Look forward to the next time.
Thanks again to Dr. Chad Lavender of Marshall. Again, if you need to know more about the fertilized ACL, you can check out his website. You can check out my website, undertheknife.substack.com, where I've had some fairly extensive pieces about this technology. I'm excited about it. The idea of getting back to competition in 6 months. I've got an article about Audrey Biggs, who was mentioned there, that explains exactly how the whole rehab went. Was one of the most read pieces from a couple of years ago, and it still holds true. I'm very curious to see when athletes are going to start demanding this, are going to start exploring this as an option to get them back even quicker, maybe not better, but quicker. Back to the field, somebody like a Ronald Acuna, who's had this twice and is looking really good this spring, I'm told. It doesn't happen too much in baseball, but we've seen it, and we see it a lot in football. We see it a lot in soccer. Unfortunately, we see it in basketball. And here's a technology that can move these things forward. Well, listen, want to thank everybody for tuning in today. Thanks to Fox One for sponsoring the WBC coverage. Be sure to check that out. Thanks to everyone at the Foul Territory Network, but most importantly, thanks you. Thanks for checking out Injury Territory. Make sure you like, subscribe, hype, ding, bell, whatever. Do all that stuff. And we'll see you next time here on Injury Territory.